Question 1. Investigation of a 68-year-old male with a history of chronic kidney disease presenting with generalized weakness, nausea, and a palpable pulse rate of 50 beats per minute. His skin is cool and clammy, and he reports a decreased urine output over the past 24 hours. He denies chest pain or shortness of breath. What is the most appropriate initial management approach for this advanced EMT? Option A. Administer oxygen. Establish intravenous access with normal saline at a slow to moderate rate, and prepare for rapid transport to the nearest appropriate medical facility. Option B. Reassure the patient, monitor vital signs, and await further instructions from medical direction due to the chronic nature of his condition. Option C. Focus on obtaining a detailed dietary history and administer a potassium-binding agent to address potential hyperkalemia. Option D. Initiate immediate administration of a rapid bolus of intravenous normal saline and administer a loop diuretic to promote urine output. Correct answer is A. Administer oxygen. Establish intravenous access with normal saline at a slow to moderate rate, and prepare for rapid transport to the nearest appropriate medical facility. Explanation. This scenario presents a professionally challenging situation due to the potential for rapid deterioration in a patient with known chronic kidney disease, CKD, experiencing symptoms suggestive of acute kidney injury, AKI, superimposed on their chronic condition. The challenge lies in differentiating the immediate life threats from the chronic underlying issues and managing them concurrently within the scope of advanced EMT practice. Adhering strictly to NREMT guidelines, careful judgment is required to prioritize interventions that stabilize the patient while gathering information to guide further management. The correct approach represents best professional practice by focusing on immediate life-saving interventions and a systematic assessment that aligns with NREMT protocols for medical emergencies. This includes ensuring airway, breathing, and circulation, ABCs, managing potential electrolyte imbalances through appropriate fluid administration, and considering the patient's history of CKD. The NREMT framework emphasizes a patient-centered approach, prioritizing interventions based on the severity of signs and symptoms and the patient's underlying conditions. This approach is ethically sound as it aims to provide the highest level of care within the EMT scope, minimizing harm and maximizing benefit. An incorrect approach that focuses solely on the chronic nature of the patient's kidney disease without addressing acute symptoms would be a regulatory and ethical failure. This would neglect the immediate threat posed by AKI, potentially leading to severe complications like hyperkalemia or fluid overload, which are within the NREMT scope to manage. Another incorrect approach that involves administering medications outside the EMT scope of practice, such as certain diuretics or potassium-binding agents, would be a direct violation of NREMT regulations and could result in patient harm. Failing to obtain a thorough history, including recent changes in diet, medication, or fluid intake, would also be a failure in professional practice, as this information is crucial for guiding management and is expected within the NREMT assessment framework. Professional reasoning in similar situations should involve a structured approach. First, ensure scene safety and personal protection. Second, conduct a rapid primary assessment focusing on ABCs and critical findings. Third, gather a focused history and perform a secondary assessment, paying close attention to signs and symptoms related to renal dysfunction and potential complications. Fourth, consider the patient's known medical history, especially chronic conditions like CKD, and how they might influence the current presentation. Fifth, initiate appropriate interventions within the EMT scope of practice, prioritizing those that address immediate life threats. Finally, continuously reassess the patient's condition and the effectiveness of interventions, preparing for definitive care by higher levels of EMS or hospital personnel. Question 2. What factors determine the selection between an oropharyngeal airway OPA and a nasopharyngeal airway NPA in a patient presenting with altered mental status and signs of airway compromise, specifically when facial trauma is a significant concern? Option A. The presence or absence of a gag reflex and the integrity of the nasal passages and skull base. Option B. The patient's age and the presence of pulse deficit. Option C. The patient's respiratory rate and the presence of bilateral breath sounds. Option D. The duration of the patient's altered mental status and the presence of peripheral cyanosis. The correct answer is A. The presence or absence of a gag reflex and the integrity of the nasal passages and skull base. Explanation. Scenario analysis. This scenario presents a common challenge in prehospital care where a patient exhibits signs of airway compromise but has specific anatomical considerations that could complicate the use of standard airway adjuncts. The professional challenge lies in accurately assessing the patient's airway status, identifying potential contraindications, and selecting the most appropriate intervention to maintain a patent airway while minimizing the risk of iatrogenic injury. The need for rapid, yet precise, decision-making under pressure is paramount. Correct approach analysis. The correct approach prioritizes patient safety and the principle of do no harm by considering the specific anatomical features of the patient. In a patient with suspected facial trauma, particularly involving the nasal passages, the use of a nasopharyngeal airway, NPA, is contraindicated due to the risk of further injury, epistaxis, or intracranial intubation. The oropharyngeal airway, OPA, is generally safer in this context, provided there are no contraindications such as a gag reflex or evidence of oral trauma that would be exacerbated by its insertion. The NREMT Advanced EMT scope of practice emphasizes assessment and appropriate intervention based on patient presentation and contraindications. Incorrect approach is analysis. Selecting an NPA without considering the facial trauma is a direct violation of safe practice guidelines and NREMT protocols. This could lead to severe complications, including hemorrhage, displacement of bone fragments into the cranial cavity, or obstruction of the airway, all of which represent significant ethical and regulatory failures. Attempting to insert an OPA without assessing for a gag reflex or other contraindications, or if there is significant oral bleeding, could lead to laryngospasm, aspiration, or further airway obstruction, again constituting a failure to adhere to established protocols and patient safety standards. Choosing to forego any airway adjunct despite signs of compromise, relying solely on positive pressure ventilation without addressing the underlying obstruction, is also a failure to provide appropriate care and may not adequately maintain airway patency, potentially leading to hypoxia and further patient deterioration. Professional reasoning. Professionals should employ a systematic approach to airway management. This begins with a rapid assessment of airway patency, breathing and circulation, ABC. If airway compromise is suspected, the next step is to identify the cause and any contraindications to specific interventions. For basic airway adjuncts, this involves assessing for the presence of a gag reflex, for OPA, and evaluating the integrity of the nasal passages and skull base, for NPA. When contraindications exist for one adjunct, the alternative should be considered, or other advanced airway management techniques may be necessary if within scope. Documentation of the assessment, decision-making process, and interventions is crucial for continuity of care and legal protection. Question 3. When evaluating the placement of an endotracheal tube in a patient following successful laryngoscopy and insertion, which of the following methods represents the most reliable and NREMT-compliant approach for confirming tracheal placement? Option A. Observing for condensation within the ETT, followed by securing the tube. Option B. Auscultating for bilateral breath sounds and absence of epigastric sounds, followed by immediate securing of the ETT. Option C. Utilizing quantitative waveform capnography as the primary confirmation method, supplemented by auscultation before securing the ETT. Option D. Relying solely on the presence of chest rise with ventilation, without further objective confirmation. Correct answer is B. Auscultating for bilateral breath sounds and absence of epigastric sounds, followed by immediate securing of the ETT. Explanation. This scenario presents a common but critical challenge in advanced airway management. Confirming endotracheal tube placement in a patient with potential for altered breath sounds. The primary goal is to ensure the ETT is in the trachea and not the esophagus, which is a life-threatening complication. The NREMT Advanced EMT certification exam emphasizes the importance of adhering to established protocols and utilizing available technology for patient safety. The correct approach prioritizes objective confirmation of ETT placement using capnography, supplemented by auscultation. Capnography provides a continuous, objective measure of carbon dioxide exhaled from the lungs, which is the gold standard for confirming tracheal intubation. This aligns with NREMT guidelines and best practices, which mandate the use of a quantitative waveform capnography device as the primary means of confirming ETT placement. Auscultation, while a valuable adjunct, can be misleading in certain patient populations, e.g., those with significant lung disease, obesity, or recent CPR, making it insufficient as the sole method of confirmation. Securing the ETT promptly after confirmation prevents dislodgement, further safeguarding the airway. Incorrect approaches fail to meet the NREMT stringent requirements for airway management. Relying solely on auscultation, even with bilateral breath sounds, is a significant regulatory and ethical failure because it lacks the objective confirmation provided by capnography. This could lead to esophageal intubation, a direct violation of the duty to provide safe and effective care. Failure to use capnography when available and indicated is a deviation from accepted standards of care and NREMT protocols. Another incorrect approach might involve delaying securing the ETT until after other interventions, which increases the risk of accidental dislodgement and airway compromise. This demonstrates a lack of understanding of the critical importance of immediate ETT stabilization post-confirmation. Professional decision-making in this situation requires a systematic approach. 1. Prepare all necessary equipment beforehand. 2. Pre-oxygenate the patient effectively. 3. Perform laryngoscopy and visualize the vocal cords. 4. Insert the ETT. 5. Immediately confirm placement using quantitative waveform capnography. 6. Auscultate for bilateral breath sounds and absence of epigastric sounds as secondary confirmation. 7. Secure the ETT. 8. Reconfirm placement after securing and with any patient movement or ventilation changes. This structured process, heavily reliant on objective data like capnography, minimizes the risk of error and ensures patient safety, reflecting the core principles of emergency medical care as defined by the NREMT. Question 4. The audit findings indicate a pattern of delayed or ineffective airway management in trauma patients presenting with stridor. Considering a 45-year-old male involved in a motor vehicle collision, found with significant facial trauma and audible inspiratory stridor, which of the following anatomical structures is the most critical to assess and consider for immediate intervention to alleviate the stridor? Option A. The nasopharynx. Option B. The epiglottis and larynx. Option C. The oropharynx. Option D. The vocal cords. The correct answer is B. The epiglottis and larynx. Explanation. Scenario analysis. This scenario presents a common but critical challenge in airway management. The patient's presentation with stridor and a history of trauma immediately raises concerns about upper airway obstruction. The challenge lies in rapidly and accurately identifying the likely source of the obstruction within the upper airway anatomy to guide appropriate intervention, all while adhering to NREMT scope of practice and established protocols. Misinterpreting the signs or delaying appropriate action can lead to rapid patient deterioration and adverse outcomes. Correct approach analysis. The correct approach prioritizes the most likely and immediately life-threatening cause of stridor in a trauma patient. Stridor, particularly inspiratory stridor, is a hallmark of upper airway obstruction. In the context of trauma, the epiglottis and larynx are highly susceptible to edema or direct injury, which can rapidly compromise the airway. Therefore, focusing on the potential for laryngeal or epiglottic involvement and considering interventions that directly address this represents best professional practice. This aligns with NREMT guidelines that emphasize rapid assessment and management of compromised airways, prioritizing interventions that secure the airway at the highest possible level to prevent further compromise. The ability to differentiate between pharyngeal and laryngeal obstruction is crucial for effective treatment. Incorrect approaches analysis. One incorrect approach would be to focus solely on the nasopharynx or oropharynx without considering the deeper structures. While pharyngeal swelling can contribute to airway compromise, stridor is more indicative of obstruction at or below the level of the vocal cords. Focusing on pharyngeal suctioning or positioning without addressing potential laryngeal edema or trauma would be insufficient and potentially delay critical interventions. This failure to consider the full spectrum of upper airway anatomy and pathology, particularly in a trauma patient, violates the principle of comprehensive patient assessment and management mandated by NREMT standards. Another incorrect approach would be to immediately attempt a blind insertion of an advanced airway device without a clear indication or understanding of the obstruction's location. While advanced airways are within the EMT scope, their indiscriminate use in the presence of stridor without a clear diagnosis of the obstruction's origin can be ineffective or even exacerbate the problem, especially if the obstruction is high in the larynx. This demonstrates a lack of analytical reasoning and adherence to evidence-based practice, which is a cornerstone of NREMT certification. A third incorrect approach would be to administer medications that could potentially worsen airway obstruction, such as certain sedatives or muscle relaxants, without first securing the airway or understanding the cause of the stridor. While medication administration is part of the EMT role, it must be guided by a thorough assessment and understanding of the patient's physiological state and the potential impact of the drug on the compromised airway. This represents a failure to apply critical thinking and a disregard for patient safety, which are fundamental ethical and regulatory requirements for NREMT-certified providers. Professional reasoning. Professionals should approach this scenario by first recognizing the urgency of stridor in a trauma patient. The decision-making process should involve a rapid assessment of the airway, focusing on the signs and symptoms that point to the location of the obstruction. This includes considering the patient's mechanism of injury and any visible signs of trauma to the head, neck, or face. The EMT must then correlate these findings with their knowledge of upper airway anatomy and physiology to form a differential diagnosis for the cause of the stridor. Based on this assessment, the EMT should select the most appropriate intervention that directly addresses the suspected cause of obstruction, prioritizing airway patency and oxygenation, while remaining within their defined scope of practice and adhering to local protocols. This iterative process of assessment, diagnosis, and intervention, guided by a strong understanding of anatomy and physiology, is essential for effective patient care. Question 5. The efficiency study reveals that in patients presenting with acute dyspnea, the most critical factor in determining appropriate per-hospital management for an advanced EMT, as defined by NREMT guidelines, is the ability to differentiate between primary impairments in alveolar gas exchange versus those primarily affecting the mechanics of breathing, considering the impact on ventilation perfusion matching. Which of the following approaches best reflects this principle? Option A. Prioritizing interventions that directly improve oxygenation and ventilation based on a comprehensive assessment of breath sounds, work of breathing, and patient-reported dyspnea, while considering the potential for altered respiratory drive. Option B. Focusing solely on the patient's subjective feeling of breathlessness and administering bronchodilators if the patient has a history of asthma. Option C. Relying on a rapid respiratory rate as the primary indicator for initiating positive pressure ventilation without further physiological assessment. Option D. Administering high-flow oxygen to all patients experiencing shortness of breath to ensure adequate oxygen saturation, regardless of underlying cause. The correct answer is A. Prioritizing interventions that directly improve oxygenation and ventilation based on a comprehensive assessment of breath sounds, work of breathing, and patient-reported dyspnea, while considering the potential for altered respiratory drive. Explanation. The efficiency study reveals a common challenge in per-hospital care, differentiating between the physiological mechanisms underlying respiratory distress in different patient populations. As an advanced EMT certified by the NREMT, understanding the nuances of respiratory physiology is paramount for accurate assessment and effective treatment. This scenario is professionally challenging because subtle differences in the mechanics of breathing, gas exchange, or the regulation of respiration can lead to misdiagnosis and inappropriate interventions, potentially harming the patient. The NREMT certification emphasizes a strong foundation in these physiological principles to ensure safe and effective patient care within the established scope of practice. The correct approach represents best professional practice because it directly applies the NREMT emphasis on understanding the fundamental principles of respiratory physiology to differentiate between conditions. It requires the advanced EMT to analyze the patient's presentation through the lens of ventilation perfusion matching and the body's compensatory mechanisms for impaired gas exchange, aligning with the NREMT focus on evidence-based practice and critical thinking. This approach ensures that interventions are targeted to the underlying physiological problem rather than just the symptoms, thereby maximizing patient benefit and adhering to the NREMT standards for advanced life support. An incorrect approach that focuses solely on the subjective sensation of shortness of breath without considering the underlying physiological cause fails to meet NREMT standards. This oversight can lead to treating a symptom rather than the root cause, potentially delaying appropriate interventions for conditions like pulmonary embolism or severe bronchospasm, which have distinct pathophysiological mechanisms affecting ventilation and perfusion. Such an approach demonstrates a lack of deep physiological understanding, a core competency for NREMT certification. Another incorrect approach that prioritizes administering oxygen without assessing the patient's baseline oxygen saturation or considering the potential for hypercapnic drive in certain chronic lung diseases is also professionally unacceptable. While oxygen is a critical intervention, its administration must be guided by physiological assessment and understanding of its effects on gas exchange and respiratory drive. The NREMT expects advanced EMTs to make informed decisions about oxygen therapy based on patient presentation and physiological status, not as a blanket treatment. This approach risks exacerbating underlying conditions or masking critical signs of respiratory failure. A third incorrect approach that relies on a single vital sign, such as respiratory rate, to dictate treatment without a comprehensive assessment of the patient's overall respiratory status, including breath sounds, work of breathing, and mental status, is also a failure to meet NREMT standards. Respiratory rate is just one component of respiratory assessment. A thorough understanding of respiratory physiology, as tested by the NREMT, requires integrating multiple data points to form a complete picture of the patient's ventilatory and gas exchange capabilities. The professional decision-making process for similar situations should involve a systematic approach. 1. Assess the patient's chief complaint and history of present illness, looking for clues related to respiratory distress. 2. Perform a thorough respiratory assessment, including inspection, palpation, percussion, and auscultation, noting the work of breathing, breath sounds, and any adventitious sounds. 3. Evaluate vital signs, paying close attention to respiratory rate, depth, rhythm, and oxygen saturation. 4. Consider the patient's underlying medical history, as pre-existing conditions can significantly alter respiratory physiology. 5. Apply knowledge of respiratory physiology to differentiate between potential causes of distress, focusing on mechanisms of impaired ventilation, gas exchange, and regulation. 6. Formulate a differential diagnosis based on the assessment findings and physiological understanding. 7. Select interventions that are most likely to address the identified physiological derangements, adhering to the NREMT scope of practice for advanced EMTs. 8. Continuously reassess the patient's response to interventions and adjust the treatment plan accordingly. Question 6. The assessment process reveals a 68-year-old male in moderate respiratory distress with audible stridor. He is conscious but lethargic, with a respiratory rate of 28 breaths per minute and an oxygen saturation of 88% on room air. Initial attempts at jaw thrust and insertion of an oropharyngeal airway have not improved his breathing. His gag reflex is diminished. Which of the following is the most appropriate next step in managing this patient's airway? Option A. Continue with repeated attempts at jaw thrust and oropharyngeal airway insertion until significant improvement is noted. Option B. Proceed with an attempt at endotracheal intubation using a laryngoscope and endotracheal tube. Option C. Attempt insertion of a laryngeal mask airway, LMA, after ensuring adequate jaw support and head tilt-chin lift. Option D. Administer a nebulized bronchodilator and reassess breathing in 5 minutes. The correct answer is C. Attempt insertion of a laryngeal mask airway, LMA, after ensuring adequate jaw support and head tilt-chin lift. Explanation. This scenario presents a common challenge in advanced airway management. A patient with a compromised airway who is not responding to initial interventions. The professional challenge lies in rapidly and effectively securing the airway to ensure adequate ventilation and oxygenation, while adhering to NREMT scope of practice and establish protocols for supraglottic airway devices. The decision-making process must balance the urgency of the situation with the need for precise technique and appropriate device selection. The correct approach involves recognizing the limitations of basic airway maneuvers and the indications for a supraglottic airway. The laryngeal mask airway, LMA, is a suitable device in this context due to its efficacy in bypassing the upper airway obstruction and facilitating ventilation when endotracheal intubation is difficult or not immediately feasible. Proper insertion technique, including correct positioning, inflation of the cuff, and confirmation of placement through chest rise and absence of epigastric sounds, is paramount. This aligns with NREMT guidelines that permit advanced EMTs to manage supraglottic airways when indicated and within their training. An incorrect approach would be to continue with basic airway maneuvers indefinitely, without escalating to a more definitive airway adjunct when initial efforts fail. This prolongs hypoxia and can lead to irreversible patient harm, representing a failure to act within the scope of practice and a deviation from the standard of care. Another incorrect approach would be to attempt endotracheal intubation without proper training or equipment, which is outside the NREMT advanced EMT scope and carries significant risks of complications. Attempting to insert a supraglottic airway without confirming proper placement, or failing to troubleshoot common issues like air leaks or inadequate ventilation, also constitutes a failure to meet professional standards and could result in ineffective ventilation and patient deterioration. Professionals should employ a systematic approach, assess the airway, attempt basic maneuvers, and if unsuccessful or if the patient's condition deteriorates, consider and prepare for supraglottic airway insertion. This decision is guided by the patient's presentation, the limitations of basic interventions, and the availability of appropriate equipment and training. Continuous reassessment of ventilation and oxygenation is critical throughout the process. Question 7. Benchmark analysis indicates that an advanced EMT responding to a patient with a history of COPD presence with acute shortness of breath and audible wheezing. The patient's vital signs are stable, but they appear uncomfortable and are using accessory muscles to breathe. Considering the pharmacology of respiratory medications and NREMT guidelines, which of the following represents the most appropriate initial pharmacological intervention for this patient's acute presentation? Option A. Administer a long-acting beta agonist LABA via nebulizer. Option B. Administer a short-acting beta agonist SABA via nebulizer. Option C. Administer a corticosteroid via nebulizer. Option D. Administer an anticholinergic medication via nebulizer. The correct answer is B. Administer a short-acting beta agonist SABA via nebulizer. Explanation. Scenario analysis. This scenario presents a common but critical challenge in advanced pre-hospital care, differentiating the underlying cause of acute respiratory distress in a patient with a history of chronic lung disease. The presence of wheezing and shortness of breath can be indicative of bronchospasm, but also potentially a sign of worsening heart failure or even an infectious process. The EMT must rapidly assess the patient, consider the patient's medical history, and select the most appropriate pharmacological intervention based on the suspected etiology, while adhering to NREMT scope of practice and established treatment protocols. Misinterpretation can lead to delayed or incorrect treatment, potentially exacerbating the patient's condition. Correct approach analysis. The correct approach prioritizes the administration of a short-acting beta agonist SABA like albuterol. This aligns with NREMT guidelines for advanced EMTs in managing acute respiratory distress with signs of bronchospasm. SABA work by relaxing the smooth muscles of the airways, leading to bronchodilation and improved airflow. This is the first-line treatment for acute exacerbations of conditions like COPD or asthma, which are common in patients presenting with these symptoms. The NREMT curriculum emphasizes understanding the indications, contraindication, and administration of these essential medications. Incorrect approaches analysis. Administering a corticosteroid as the initial treatment for acute bronchospasm is incorrect. While corticosteroids are crucial for managing inflammation in chronic respiratory conditions and are used to prevent exacerbations, their onset of action is delayed. They are not indicated for immediate relief of acute bronchospasm. This represents a failure to apply knowledge of the pharmacological mechanisms of action and appropriate timing of medication administration, as outlined in NREMT training. Administering a long-acting beta agonist LABA as the primary treatment for acute bronchospasm is also incorrect. LABA are designed for long-term maintenance therapy and bronchodilation, not for rapid relief of acute symptoms. Their use in an acute exacerbation without a concurrent SABA can be ineffective and potentially mask worsening symptoms. This demonstrates a misunderstanding of the different classes of beta agonists and their specific therapeutic roles, a key component of NREMT pharmacology education. Administering an anticholinergic medication without first attempting a SABA is a less optimal approach for immediate relief of bronchospasm. While anticholinergics can provide bronchodilation, their onset of action is generally slower than SABA, and they are often used in combination with SABA for synergistic effects in certain respiratory conditions. Prioritizing the SABA aligns with the most rapid and effective initial management of acute bronchospasm, as taught by the NREMT. Professional reasoning. When faced with a patient experiencing acute respiratory distress with signs of bronchospasm, the EMT must employ a systematic approach. This involves 1. rapid patient assessment, including vital signs, lung sounds, and patient history. 2. Consideration of the most likely underlying cause based on presentation and history. 3. Application of NREMT-approved pharmacological interventions based on the suspected etiology and the medication's mechanism of action and onset of effect. 4. Continuous reassessment of the patient's response to treatment. In this case, the presence of wheezing strongly suggests bronchospasm, making a SABA the most appropriate initial pharmacological intervention. Question 8. Quality control measures reveal that an advanced EMT candidate, when presented with a scenario involving a patient exhibiting labored breathing, diminished breath sounds in the left lower lobe, and a pulse oximetry reading of 92%, failed to consider the implications of the capnography waveform, which displayed a plateau phase that was significantly elevated and prolonged. Which of the following best describes the critical oversight in the candidate's respiratory assessment process according to NREMT standards? Option A. The candidate appropriately disregarded the capnography waveform due to the patient's relatively stable pulse oximetry reading. Option B. The candidate failed to integrate objective capnography data with physical examination findings and pulse oximetry to fully assess ventilation and perfusion status. Option C. The candidate prioritized auscultation findings over all other assessment modalities. Option D. The candidate correctly focused on the pulse oximetry reading as the primary indicator of respiratory compromise. The correct answer is B. The candidate failed to integrate objective capnography data with physical examination findings and pulse oximetry to fully assess ventilation and perfusion status. Explanation. This scenario presents a common challenge in advanced emergency medical care, interpreting complex respiratory data in a critically ill patient. The professional challenge lies in synthesizing information from multiple assessment modalities, including physical examination findings, vital signs, and advanced monitoring, to arrive at an accurate diagnosis and initiate appropriate interventions. The NREMT Advanced EMT Certification Exam emphasizes the ability to apply this knowledge within the established scope of practice and regulatory framework. The correct approach represents best professional practice because it systematically integrates all available data points, prioritizing objective findings and established protocols. This aligns with NREMT guidelines that stress a comprehensive and evidence-based approach to patient assessment and management. Specifically, it reflects the expectation that an advanced EMT will not only perform, but also interpret findings from inspection, palpation, percussion, and auscultation, alongside vital signs like pulse oximetry and capnography, to guide clinical decision-making. This systematic integration ensures that interventions are targeted and effective, minimizing the risk of misdiagnosis or delayed treatment, which are critical ethical and professional responsibilities. An incorrect approach would fail to integrate all relevant data, leading to a potentially incomplete or inaccurate assessment. For instance, relying solely on pulse oximetry without considering physical exam findings or capnography can be misleading, as pulse oximetry may not accurately reflect ventilation status in certain conditions. This failure to perform a thorough, multimodal assessment violates the NREMT emphasis on comprehensive patient evaluation. Another incorrect approach might be to over-rely on a single piece of data, such as a normal respiratory rate, while ignoring signs of increased work of breathing or abnormal breath sounds. This demonstrates a lack of critical thinking and an inability to synthesize information, which is a core competency for an advanced EMT. Ethically, failing to utilize all available assessment tools and data points to provide the best possible patient care constitutes a breach of the duty to act and a failure to adhere to professional standards. The professional decision-making process for similar situations involves a structured approach. First, perform a complete physical assessment of the respiratory system, including inspection, palpation, percussion, and auscultation. Second, obtain and interpret vital signs, including respiratory rate, rhythm, depth, and pulse oximetry. Third, if available and indicated, utilize advanced monitoring such as capnography and interpret its readings in conjunction with other findings. Fourth, synthesize all collected data to form a differential diagnosis and determine the most appropriate course of action, always within the scope of practice and established protocols. This iterative process of data collection, interpretation, and synthesis is fundamental to effective emergency medical care. Question 9. Governance review demonstrates that advanced EMTs are expected to manage patients requiring mechanical ventilation, When a patient receiving positive pressure ventilation via a mechanical ventilator begins to exhibit increased work of breathing and audible wheezing, which of the following actions is the most appropriate initial response? Option A. Assess the patient's chest rise to ensure adequate tidal volume and listen for bilateral breath sounds, adjusting the delivered tidal volume if chest rise is insufficient. Option B. Discontinue the mechanical ventilator and initiate bag valve mask (BVM) ventilation to re-establish a more controlled airway. Option C. Increase the respiratory rate to compensate for the increased work of breathing and potential air trapping. Option D. Immediately increase the positive end expiratory pressure (PEEP) to improve oxygenation and reduce the work of breathing. The correct answer is A. Assess the patient's chest rise to ensure adequate tidal volume and listen for bilateral breath sounds, adjusting the delivered tidal volume if chest rise is insufficient. Explanation. This scenario presents a common yet critical challenge in advanced per-hospital care, managing a patient requiring mechanical ventilation where initial settings may not be optimal, necessitating rapid assessment and adjustment. The professional challenge lies in recognizing subtle signs of inadequate ventilation or potential complications and intervening appropriately, balancing the need for effective gas exchange with the risk of iatrogenic injury. Careful judgment is required to interpret patient response, ventilator data, and clinical presentation to ensure patient safety and optimal outcomes. The correct approach represents best professional practice by prioritizing patient assessment and clinical indicators over solely relying on preset ventilator parameters. The NREMT Advanced EMT certification emphasizes the ability to critically evaluate a patient's response to interventions, adjusting tidal volume to achieve adequate chest rise, and observing for signs of patient ventilator dysynchrony or barotrauma are direct applications of NREMT guidelines for mechanical ventilation. This approach aligns with the principle of individualized patient care, ensuring ventilation meets the patient's specific needs and minimizing risks. An incorrect approach that focuses solely on maintaining a specific respiratory rate without assessing tidal volume or patient tolerance fails to address the core goal of effective ventilation, which is adequate gas exchange and minimizing work of breathing. This could lead to hypoventilation or hyperventilation, both of which have significant clinical consequences. Another incorrect approach, such as immediately discontinuing mechanical ventilation without a clear clinical indication or alternative plan, disregards the patient's dependence on the device and could result in respiratory decompensation. A third incorrect approach, blindly increasing positive end expiratory pressure, PEEP, without considering its potential to cause barotrauma or hemodynamic compromise, demonstrates a lack of understanding of ventilator mechanics and patient physiology, violating principles of safe mechanical ventilation. Professional decision-making in such situations requires a systematic approach. First, assess the patient's overall clinical status and vital signs. Second, evaluate the ventilator's delivered parameters and the patient's interaction with the device. Third, consider the underlying pathology. And finally, implement adjustments based on evidence-based practice and patient response, continuously reassessing for efficacy and adverse effects. This iterative process ensures that mechanical ventilation is a therapeutic tool, not a source of harm. Question 10. The risk matrix shows a patient presenting with sudden onset chest pain radiating to the left arm, shortness of breath, and diaphoresis. The advanced EMT has obtained a 12-lead electrocardiogram, ECG, which shows ST segment elevation in leads Roman 2, Roman 3, and a VF. Which of the following actions is the most appropriate next step in the cardiac assessment of this patient? Option A. Focus solely on the ECG findings and initiate immediate chest compressions. Option B. Administer aspirin and nitroglycerin and prepare for immediate transport to a cardiac catheterization lab. Option C. Reassess the patient's blood pressure and administer a bolus of intravenous fluids. Option D. Obtain a detailed past medical history of all cardiac conditions and medications. The correct answer is B. Administer aspirin and nitroglycerin and prepare for immediate transport to a cardiac catheterization lab. Explanation. This scenario presents a professional challenge due to the critical nature of cardiac assessment and the potential for rapid patient deterioration. The advanced EMT must integrate multiple data points from patient history, physical examination, vital signs, and ECG interpretation to form an accurate diagnosis and initiate appropriate treatment. The NREMT certification exam emphasizes the ability to apply these skills in a systematic and evidence-based manner, adhering to established protocols and guidelines. The correct approach represents best professional practice because it prioritizes a comprehensive and systematic assessment. This aligns with NREMT standards, which require a thorough evaluation of the patient's cardiac status, obtaining a detailed patient history, performing a focused physical exam, accurately assessing vital signs, and interpreting the ECG are all essential components of a complete cardiac assessment as outlined in NREMT curriculum and guidelines. This systematic approach ensures that all relevant information is gathered, leading to a more accurate diagnosis and effective treatment plan, thereby minimizing the risk of adverse outcomes and upholding the standard of care. An incorrect approach that neglects a key component of the cardiac assessment, such as failing to obtain a patient history or perform a physical examination, represents a significant regulatory and ethical failure. This omission could lead to a misdiagnosis or delayed treatment, violating the NREMT mandate to provide competent patient care. Furthermore, misinterpreting an ECG without correlating it with the patient's clinical presentation is a direct failure to apply critical thinking skills, which are a cornerstone of advanced emergency medical care. Relying solely on one piece of data, like vital signs, without considering the broader clinical picture, is also a failure to meet the comprehensive assessment requirements. Professional decision-making in similar situations should follow a structured approach. 1. Scene safety and initial impression. 2. Primary assessment of death. 3. Focused history and physical examination including cardiac-specific questions and maneuvers. 4. Vital signs and ECG acquisition and interpretation. 5. Development of a differential diagnosis. 6. Implementation of appropriate interventions based on assessment findings and established protocols. 7. Ongoing reassessment and modification of treatment as needed. This systematic process ensures that all critical elements of patient care are addressed, promoting patient safety and optimal outcomes. Question 11. Governance review demonstrates a need to refine protocols for managing patients experiencing acute respiratory distress. An advanced EMT arrives on scene to find a 68-year-old male with a history of COPD, who is now experiencing increased shortness of breath, audible wheezing, and accessory muscle use. His oxygen saturation is 88% on room air, and he appears anxious and diaphoretic. Which of the following management approaches best aligns with NREMT advanced EMT guidelines for this respiratory emergency? Option A. Administer supplemental oxygen at a rate that maintains an oxygen saturation of 94–96% and await further orders from medical direction for any other interventions. Option B. Administer high-flow oxygen via non-rebreather mask, position the patient in a semi-Fowler's position, and prepare for potential advanced airway interventions if the patient's condition deteriorates. Option C. Immediately administer a prescribed bronchodilator via nebulizer, as the patient has a known history of COPD. Option D. Initiate a detailed patient history to ascertain the exact onset and triggers of his current symptoms before any interventions. The correct answer is B. Administer high-flow oxygen via non-rebreather mask, position the patient in a semi-Fowler's position, and prepare for potential advanced airway interventions if the patient's condition deteriorates. Explanation. This scenario presents a professionally challenging situation due to the rapid deterioration of a patient with a known respiratory condition and the need for immediate, evidence-based intervention within the scope of advanced EMT practice as defined by the NREMT. The challenge lies in accurately assessing the patient's current state, differentiating between potential exacerbations of their underlying COPD and a new, acute respiratory event, and initiating appropriate management without delay, all while adhering to NREMT guidelines and protocols. The correct approach represents best professional practice because it prioritizes a systematic assessment, including vital signs and lung sounds, to identify the most likely cause of the patient's distress. Administering supplemental oxygen, positioning the patient for optimal breathing, and preparing for advanced airway management or transport based on the assessment findings are all within the NREMT advanced EMT scope of practice for respiratory emergencies. This approach aligns with NREMT guidelines that emphasize prompt recognition, assessment, and intervention for respiratory compromise, ensuring patient safety and maximizing the chances of a positive outcome. An incorrect approach that involves solely administering a bronchodilator without a thorough assessment fails to address potential underlying causes or complications, such as a pneumothorax or pulmonary edema, which would not be effectively treated by a bronchodilator alone. This represents a regulatory failure by not adhering to the systematic assessment protocols mandated by NREMT for respiratory emergencies. Another incorrect approach, such as delaying transport to conduct a lengthy history interview, poses a significant ethical and regulatory failure. NREMT guidelines stress the importance of timely transport for patients with severe respiratory distress, and prolonged on-scene assessment when definitive care is not immediately available can lead to irreversible patient harm. Finally, an approach that involves administering medications outside the advanced EMT scope of practice, such as intravenous steroids without specific medical direction or protocol, is a clear regulatory and ethical violation, potentially leading to adverse patient outcomes and professional disciplinary action. Professional reasoning in such situations should involve a rapid primary assessment, followed by a focused secondary assessment, continuous reassessment, and a clear understanding of the NREMT scope of practice for advanced EMTs. Decision-making should be guided by established protocols, clinical judgment, and a commitment to patient advocacy, always prioritizing the patient's immediate needs and safety. Question 12. Market research demonstrates that patients experiencing acute respiratory distress often express a strong desire to avoid mechanical assistance. You are dispatched to a residence for a 68-year-old male complaining of severe shortness of breath. Upon arrival, the patient is alert but visibly struggling to breathe, speaking in single words. He is hypotensive and tachycardic. You determine he is a candidate for CPAP. When you explain the procedure and its potential benefits, he adamantly refuses, stating, "I can't stand that mask. I'd rather just try to breathe on my own." What is the most appropriate immediate course of action? Option A. Administer a mild sedative to help him tolerate the CPAP mask, as his refusal is likely due to anxiety. Option B. Attempt to further assess the patient's capacity to refuse treatment by asking him to explain his understanding of his condition and the risks of not receiving CPAP, while also exploring his specific concerns about the mask. And if he remains capable of making this decision and still refuses, document and continue to monitor. Option C. Immediately apply CPAP, explaining that it is necessary to save his life, as his refusal is likely due to his altered mental status from hypoxia. Option D. Respect the patient's refusal and withdraw care, as he is alert and has the right to refuse any medical treatment. The correct answer is B. Attempt to further assess the patient's capacity to refuse treatment by asking him to explain his understanding of his condition and the risks of not receiving CPAP, while also exploring his specific concerns about the mask. And if he remains capable of making this decision and still refuses, document and continue to monitor. Explanation. This scenario presents a professional challenge due to the conflict between a patient's expressed wishes and the perceived medical necessity of a treatment, complicated by the potential for a life-threatening condition. The advanced EMT must balance patient autonomy with their duty to provide life-saving care, all while adhering to NREMT guidelines and ethical principles. The core of the challenge lies in assessing the patient's capacity to make informed decisions when experiencing respiratory distress, which can significantly impair judgment. The correct approach represents best professional practice because it prioritizes a thorough assessment of the patient's condition and capacity before overriding their refusal. The NREMT framework emphasizes patient-centered care and the importance of informed consent. In this case, the advanced EMT must first attempt to understand the patient's reasoning for refusal, explore potential underlying causes for their distress, and assess their ability to comprehend the risks and benefits of CPAP. If the patient is deemed to have capacity, their refusal must be respected, even if it seems contrary to the provider's best judgment. However, if the patient lacks capacity due to their respiratory distress, the advanced EMT has a duty to act in the patient's best interest, which may include initiating CPAP to prevent further deterioration and potential death, while documenting the rationale thoroughly. This aligns with the ethical principle of beneficence and the legal requirement to act when a patient is unable to make rational decisions for themselves. An incorrect approach that involves immediately applying CPAP without attempting to assess the patient's capacity or understand their refusal fails to uphold patient autonomy. This could be considered a violation of the patient's right to refuse treatment, even if the provider believes it is in their best interest. Bypasses the crucial step of determining if the patient is capable of making such a decision. Another incorrect approach would be to simply leave the scene without further intervention if the patient refuses, without adequately assessing their capacity or exploring alternatives. This could be seen as abandoning the patient, especially if their condition is life-threatening and they are unable to make a reasoned decision. The NREMT expects providers to make a diligent effort to provide care within their scope of practice and to ensure patient safety. Professional decision-making in similar situations requires a systematic approach. 1. Assess the patient's airway, breathing, and circulation, ABCs, and vital signs to determine the severity of their respiratory distress. 2. Attempt to communicate with the patient, ascertain their understanding of their condition, and explore the reasons for their refusal of CPAP. 3. Assess the patient's mental capacity to make an informed decision. Factors to consider include their ability to understand the information provided, appreciate the consequences of their decision, and reason through the options. 4. If the patient has capacity and continues to refuse, respect their decision, document the refusal and the assessment of capacity thoroughly, and continue to monitor the patient. 5. If the patient lacks capacity, or if their condition is rapidly deteriorating and poses an immediate threat to life, the advanced EMT should proceed with the intervention CPAP. That is in the patient's best interest, documenting the rationale for overriding the refusal and the assessment of capacity. 6. Consult with medical direction if there is any uncertainty regarding capacity or the appropriate course of action. Question 13. The monitoring system demonstrates a regular, narrow complex tachycardia at a rate of 170 beats per minute. The patient is alert but reports feeling dizzy and nauseous, with a blood pressure of 90/60 mmHg. Which of the following is the most appropriate initial pharmacological intervention for this patient, according to NREMT Advanced EMT Guidelines? Option A. Administer metoprolol 5 mg Roman 4. Option B. Administer adenosine 6 mg Roman 4 push, followed by a 20 ml saline flush. Option C. Prepare for synchronized cardioversion at 75 joules. Option D. Administer amiodarone 150 mg Roman 4 over 10 minutes. Correct answer is B. Administer adenosine 6 mg Roman 4 push, followed by a 20 ml saline flush. Explanation. Scenario analysis. This scenario presents a common but critical challenge in advanced emergency care, interpreting complex cardiac rhythms and patient presentation to administer appropriate pharmacological interventions within the NREMT Advanced EMT scope of practice. The challenge lies in differentiating between various supraventricular tachycardias, SVT, and identifying the most effective and safest treatment based on the patient's hemodynamic stability, while adhering strictly to NREMT guidelines for medication administration. Misinterpretation can lead to ineffective treatment or, worse, patient harm. Correct approach analysis. The correct approach involves recognizing the patient's rapid, regular rhythm with signs of instability, which strongly suggests a hemodynamically compromising SVT. Adenosine is the first-line pharmacological intervention for stable SVT according to NREMT guidelines, as it effectively slows conduction through the AV node, often terminating the arrhythmia. The administration of a rapid Roman 4 push followed by a saline flush is the recommended procedure to ensure rapid delivery and minimize discomfort. The subsequent assessment of the patient's response is crucial for determining the next steps, whether it be a repeat dose or consideration of other interventions. This aligns with the NREMT emphasis on evidence-based practice and patient safety within the EMT-defined skill set. Incorrect approaches analysis. Administering amiodarone without first attempting adenosine for a presumed SVT is a deviation from NREMT guidelines. Amiodarone is a potent antiarrhythmic, but is typically reserved for more complex arrhythmias or when adenosine is ineffective or contraindicated. Its use in this initial presentation for SVT is not the standard of care as defined by NREMT protocols. Attempting synchronized cardioversion without first administering a pharmacological agent like adenosine is also an incorrect approach for a patient who is not overtly hypotensive or in profound distress, but rather showing signs of compromise. NREMT guidelines prioritize pharmacological intervention for stable or mildly unstable SVT before resorting to electrical therapy, which carries its own risks. Administering a beta blocker like metoprolol as the initial treatment for a presumed SVT is also not the primary NREMT recommended pharmacological intervention. While beta blockers can be used for rate control in some supraventricular arrhythmias, adenosine is specifically indicated for terminating SVT by blocking AV nodal conduction. Professional reasoning. Advanced EMTs must employ a systematic approach to cardiac emergencies. This involves 1. Rapidly assessing the patient's stability, vital signs, mental status, signs of shock. 2. Interpreting the cardiac rhythm accurately. 3. Consulting NREMT-approved protocols for the specific arrhythmia and patient stability. 4. Administering the highest priority medication or intervention as per protocol. 5. Continuously reassessing the patient's response and adjusting treatment accordingly. This structured decision-making process ensures adherence to regulatory standards and optimizes patient outcomes. Question 14. Stakeholder feedback indicates that some advanced EMTs are struggling with the prioritization of interventions during witnessed cardiac arrest scenarios, particularly when advanced airway equipment is readily available. Considering the NREMT Advanced EMT certification exams focus on current resuscitation guidelines, which of the following approaches best reflects the immediate management of a patient found in pulseless electrical activity, P, after a witnessed collapse? Option A. Immediately initiate high-quality chest compressions, attach the AED for rhythm analysis, and prepare for defibrillation if indicated, while simultaneously preparing for advanced airway placement and administering appropriate medications per ACL's guidelines. Option B. Discontinue resuscitation efforts after 5 minutes of chest compressions and ventilations if there is no palpable pulse, assuming the patient is unlikely to survive. Option C. Prioritize the immediate placement of a supraglottic airway, followed by ventilations, before initiating chest compressions. Option D. Administer a bolus of epinephrine intravenously without first confirming the patient's cardiac rhythm or initiating chest compressions. The correct answer is A. Immediately initiate high-quality chest compressions, attach the AED for rhythm analysis, and prepare for defibrillation if indicated, while simultaneously preparing for advanced airway placement and administering appropriate medications per ACL's guidelines. Explanation. This scenario presents a common implementation challenge in emergency medical services, balancing established protocols with the dynamic nature of patient care, particularly in the critical moments of cardiac arrest management. The challenge lies in the rapid assessment, decision-making, and application of advanced interventions under extreme pressure, while adhering strictly to NREMT guidelines. The correct approach represents best professional practice because it prioritizes immediate, high-quality CPR as the foundational element of resuscitation, directly aligning with NREMT emphasis on the chain of survival. The prompt recognition of cardiac arrest, followed by immediate chest compressions and prompt defibrillation when indicated, are core competencies for an advanced EMT. This approach ensures that the patient receives the most critical interventions without delay, maximizing the chance of a return of spontaneous circulation (ROSC). Adherence to current ACL's algorithms, as taught and tested by NREMT, is paramount. An incorrect approach that delays CPR to focus solely on advanced airway placement, without first establishing effective chest compressions, is a significant regulatory and ethical failure. NREMT guidelines and ACL's protocols consistently emphasize that chest compressions are the priority in cardiac arrest. Delaying compressions for advanced airway maneuvers can lead to prolonged periods of no blood flow to the brain and vital organs, drastically reducing the likelihood of survival. Furthermore, attempting advanced airway placement without adequate ventilation support during compressions is counterproductive. Another incorrect approach that involves administering medications without a clear indication or prior assessment of the patient's rhythm and response to initial resuscitation efforts is also a failure. NREMT certification requires EMT to understand the indications and contraindications for all medications they are authorized to administer. Administering medications haphazardly, without following the established ACL's algorithm, can lead to adverse effects and does not represent evidence-based practice. Finally, an incorrect approach that involves discontinuing resuscitation efforts prematurely based on subjective assessment rather than objective criteria or established protocols would be a failure. NREMT certification mandates that EMT understand the criteria for terminating resuscitation efforts, which are typically based on prolonged asystole despite aggressive interventions, lack of ROSC after a specified duration, and consultation with medical direction. The professional reasoning process for similar situations involves a systematic approach. 1. Rapidly assess the patient for signs of cardiac arrest. 2. Immediately initiate high-quality CPR. 3. Apply the AED and follow defibrillation prompts. 4. Assess the rhythm and administer appropriate medications and interventions according to ACL's protocols. 5. Continuously reassess the patient's response to interventions. 6. Communicate effectively with the team and medical direction. This structured approach ensures that all critical steps are taken in the correct sequence and in accordance with NREMT standards. Question 15. Cost-benefit analysis shows that while oxygen is a vital resource, its availability can be strained during mass casualty incidents. You are managing two patients. Patient A is experiencing severe respiratory distress with an oxygen saturation of 82% on room air and is breathing rapidly and shallowly. Patient B is conscious and alert, complaining of shortness of breath, with an oxygen saturation of 94% on room air. You have a limited supply of high-flow oxygen cylinders and non-rebreather masks. Which approach best aligns with NREMT guidelines and ethical principles for oxygen administration in this scenario? Option A. Administer high-flow oxygen via a non-rebreather mask to patient A, prioritizing the patient with the most severe hypoxia and respiratory distress. Option B. Administer high-flow oxygen via a non-rebreather mask to patient B, as they are conscious and can communicate their distress. Option C. Delay oxygen administration to patient a while you complete a full assessment of patient B and other potential patients. Option D. Administer a low concentration of oxygen via nasal cannula to patient A, as you need to conserve high-flow oxygen for potential future patients. The correct answer is A. Administer high-flow oxygen via a non-rebreather mask to patient A, prioritizing the patient with the most severe hypoxia and respiratory distress. Explanation. Scenario analysis. This scenario presents a professional challenge due to the conflict between resource limitations, limited oxygen supply, and the ethical imperative to provide the best possible care to all patients. The advanced EMT must balance the immediate needs of a critically ill patient with the potential future needs of other patients, all while adhering to NREMT guidelines and established medical protocols. This requires careful clinical judgment and an understanding of oxygen therapy principles. Correct approach analysis. The correct approach prioritizes the patient exhibiting the most severe signs of hypoxia and respiratory distress, as indicated by their low oxygen saturation and labored breathing. Administering high-flow oxygen via a non-rebreather mask is the most appropriate method to rapidly improve oxygenation in such a patient, aligning with NREMT guidelines for managing hypoxemia. This decision is ethically sound as it addresses the most urgent threat to life and is supported by established medical protocols for oxygen administration. Incorrect approaches analysis. Administering a low concentration of oxygen via nasal cannula to the patient with severe hypoxia is incorrect because it is unlikely to adequately address their critical oxygen deficit. This approach fails to meet the immediate needs of the most severely compromised patient and could lead to further deterioration, violating the principle of providing appropriate and timely care. Delaying oxygen administration to the patient with severe hypoxia while assessing other patients is incorrect. NREMT emphasizes prompt assessment and intervention for life-threatening conditions. Hypoxemia is a critical issue that requires immediate attention, and delaying treatment based on potential future needs, without a clear protocol for resource allocation in such a crisis, is a failure to provide essential care. Administering oxygen to the patient with mild hypoxia at a higher flow rate than indicated by their condition, while neglecting the severely hypoxic patient, is incorrect. This misallocates a critical resource and fails to address the most urgent need. It demonstrates a lack of clinical prioritization and adherence to appropriate oxygen delivery device selection and flow rates based on patient presentation. Professional reasoning. Professionals should employ a systematic approach to patient assessment and management. This involves rapid identification of life threats, prioritizing interventions based on severity of condition, and utilizing available resources effectively and ethically. In situations of potential resource scarcity, adherence to established protocols and consultation with medical direction are crucial. The decision-making process should always begin with the most critical patient and the most effective intervention to stabilize their condition, within the scope of practice and available equipment. Question 16. The performance metrics show a patient presenting with audible stridor, increased respiratory rate and depth, and a pulse oximetry reading of 96%. The advanced EMT is tasked with determining the most appropriate initial management strategy. Option A. Initiate airway adjuncts and consider positive pressure ventilation if indicated by work of breathing. Option B. Focus on auscultating lung sounds and documenting clear breath sounds. Option C. Administer high-flow oxygen via non-rebreather mask and reassess in 5 minutes. Option D. Reassess the pulse oximetry reading, as 96% indicates adequate oxygenation. The correct answer is A. Initiate airway adjuncts and consider positive pressure ventilation if indicated by work of breathing. Explanation. This scenario presents a common challenge in emergency medical services where subtle signs of airway compromise can be easily overlooked, leading to delayed or inappropriate interventions. The professional challenge lies in accurately interpreting a constellation of findings, moving beyond a single vital sign, and applying critical thinking to assess the severity of respiratory distress. The NREMT Advanced EMT Certification Exam emphasizes the ability to synthesize patient assessment data to determine the most appropriate course of action, adhering strictly to established protocols and best practices. The correct approach represents best professional practice because it involves a systematic and comprehensive assessment of the airway and respiratory status, as mandated by NREMT guidelines. This includes not only auscultation of lung sounds, but also a thorough evaluation of respiratory rate, depth, and effort, coupled with pulse oximetry interpretation. This multifaceted approach ensures that the advanced EMT is not solely reliant on one piece of data, but rather builds a complete picture of the patient's respiratory function. This aligns with the NREMT focus on evidence-based practice and patient safety, requiring a thorough understanding of physiological principles and their clinical application. An incorrect approach that focuses solely on a normal pulse oximetry reading, ignoring audible stridor and increased respiratory effort, represents a significant regulatory and ethical failure. The NREMT expects advanced EMTs to recognize that pulse oximetry is a valuable tool, but not the sole determinant of oxygenation or ventilation. Stridor is a direct indicator of upper airway obstruction, a critical finding that requires immediate attention regardless of the pulse oximetry reading. Failing to address stridor and increased work of breathing due to an over-reliance on a seemingly normal SpO2 value violates the NREMT emphasis on a complete patient assessment and the principle of do no harm. Another incorrect approach that prioritizes immediate administration of high-flow oxygen without further assessment of the airway itself is also professionally unacceptable. While oxygen is a crucial intervention, it does not resolve an underlying airway obstruction. The NREMT framework stresses the importance of identifying and managing the root cause of respiratory distress. Administering oxygen without addressing stridor and increased effort is a failure to perform a thorough airway assessment and can mask the severity of the underlying problem, delaying definitive airway management. A third incorrect approach that involves only listening to lung sounds and noting clear breath sounds, while disregarding the audible stridor, is also a failure to meet NREMT standards. Clear lung sounds do not negate the presence of upper airway compromise. Stridor is an audible sign of turbulent airflow through a narrowed upper airway, a critical finding that must be addressed. This approach demonstrates a lack of comprehensive airway assessment, which is a core competency for advanced EMTs. The professional decision-making process for similar situations should involve a systematic approach. First, assess for obvious signs of airway compromise, e.g., foreign body trauma, stridor, gurgling. Second, evaluate the quality of breathing, rate, depth, and effort. Third, auscultate lung sounds to assess lower airway patency and air movement. Fourth, utilize adjuncts like pulse oximetry, but interpret them in conjunction with all other findings. Finally, intervene based on the most critical findings, prioritizing airway management and ventilation over solely oxygenation if obstruction is suspected. This hierarchical approach ensures that life-threatening issues are addressed first and foremost, in accordance with NREMT certification requirements. Question 17. Assessment of a 2-year-old male presenting with a barking cough, inspiratory stridor, and mild retractions, who is conscious but irritable and drooling slightly, requires a systematic approach to differentiate between common pediatric respiratory emergencies and guide immediate management. Which of the following assessment and management strategies best aligns with NREMT Advanced EMT guidelines for this presentation? Option A. Suction the airway aggressively, administer a bronchodilator via nebulizer, and reassess for improvement before considering transport. Option B. Administer high-flow oxygen via non-rebreather mask, position the child upright, and prepare for immediate transport while maintaining a calm environment and avoiding unnecessary stimulation. Option C. Focus on obtaining a detailed history of the onset and progression of symptoms from the parents, delaying physical assessment until the child is calmer. Option D. Administer a dose of epinephrine via auto-injector and initiate rapid transport without further assessment, assuming anaphylaxis. The correct answer is B. Administer high-flow oxygen via non-rebreather mask, position the child upright, and prepare for immediate transport while maintaining a calm environment and avoiding unnecessary stimulation. Explanation: this scenario presents a professionally challenging situation due to the rapid deterioration of a pediatric patient with respiratory distress, requiring swift and accurate assessment and intervention within the scope of advanced EMT practice as defined by the NREMT. The challenge lies in differentiating between common pediatric respiratory conditions that can present with similar initial symptoms but require distinct management strategies, and the potential for rapid decompensation if mismanaged. The NREMT framework emphasizes evidence-based practice and adherence to establish protocols for patient care. The correct approach represents best professional practice by prioritizing a systematic assessment that focuses on identifying the underlying cause of the respiratory distress and initiating appropriate interventions based on the patient's presentation and the NREMT scope of practice. This includes assessing airway patency, breathing effectiveness, and circulation, while simultaneously considering the most likely etiologies based on the patient's age and clinical signs. Promptly administering oxygen, positioning the patient for optimal breathing, and preparing for advanced airway management or transport based on the severity of distress are critical steps aligned with NREMT guidelines for pediatric respiratory emergencies. An incorrect approach that involves solely focusing on a single symptom without a comprehensive assessment fails to meet the NREMT requirement for a thorough patient evaluation. This could lead to misdiagnosis and delayed or inappropriate treatment, potentially exacerbating the patient's condition. For instance, assuming a diagnosis of croup based solely on stridor without assessing for other signs of epiglottitis, such as drooling or tripod positioning, represents a failure to adhere to the NREMT emphasis on differential diagnosis and a complete physical examination. Similarly, administering medications without a clear indication or without considering potential contraindications, as dictated by NREMT protocols, would be a significant ethical and regulatory failure. Another incorrect approach would be to delay transport or definitive care when the patient's condition warrants it, violating the NREMT mandate to provide timely and appropriate medical intervention. Professional reasoning in such situations should involve a structured approach. First, ensure scene safety and don appropriate personal protective equipment. Second, conduct a rapid primary survey to identify and address life threats, airway, breathing, circulation. Third, perform a focused secondary assessment, gathering a brief history, if possible, and performing a physical examination tailored to respiratory distress in children, considering common differential diagnoses like bronchiolitis, croup, and epiglottitis. Fourth, based on the assessment findings, initiate interventions within the NREMT advanced EMT scope of practice, such as oxygen administration, suctioning, and positioning. Finally, determine the need for and initiate rapid transport to an appropriate facility, communicating effectively with medical control and the receiving hospital. Question 18. Comparative studies suggest that in a patient presenting with symptoms of decreased mentation and cool, clammy skin, a heart rate of 45 beats per minute, without any obvious signs of trauma or respiratory distress, is most likely indicative of which of the following? Option A. A primary dysfunction of the heart's intrinsic conduction system leading to inadequate cardiac output. Option B. A transient vasovagal response unrelated to cardiac electrical activity. Option C. A normal physiological response to aging in the absence of other symptoms. Option D. A secondary effect of hypothermia despite the absence of external cold exposure. The correct answer is A. A primary dysfunction of the heart's intrinsic conduction system leading to inadequate cardiac output. Explanation: scenario analysis. This scenario presents a challenge in differentiating between a primary cardiac electrical disturbance and a secondary effect of a systemic issue, requiring the advanced EMT to apply their knowledge of cardiac anatomy, physiology, and the conduction system under pressure. The ability to interpret subtle ECG changes and correlate them with patient presentation is critical for appropriate intervention. Correct approach analysis. The correct approach involves recognizing that a heart rate of 45 beats per minute, particularly in a patient with a history of cardiac issues, and presenting with symptoms of poor perfusion, strongly suggests a bradyarrhythmia originating from a failure within the heart's intrinsic conduction system. This aligns with NREMT guidelines for advanced EMTs, which emphasize the assessment and management of cardiac rhythm disturbances. The focus on identifying the underlying cause of the bradycardia, such as a sinoatrial node dysfunction or a block in the conduction pathway, is paramount for effective treatment. This approach prioritizes patient safety by addressing the immediate threat to cardiac output and organ perfusion. Incorrect approach is analysis. One incorrect approach would be to immediately administer a medication intended to increase heart rate without first thoroughly assessing the patient's cardiac rhythm and considering potential underlying causes. This bypasses the critical step of diagnosing the specific type of bradyarrhythmia and could lead to inappropriate treatment or exacerbation of the condition if the cause is, for example, a high-degree AV block where certain medications are contraindicated. This failure to diagnose before treating is a direct violation of best practice principles in emergency medical care and NREMT scope of practice. Another incorrect approach would be to attribute the slow heart rate solely to the patient's age or a presumed benign cause without further investigation. While age can be a factor in cardiac function, a symptomatic bradycardia in an otherwise potentially stable patient requires a definitive diagnosis. Dismissing the symptom without a thorough cardiac assessment and rhythm analysis is a failure to adhere to the NREMT emphasis on comprehensive patient evaluation and can lead to delayed or missed critical interventions. A third incorrect approach would be to focus exclusively on the patient's respiratory status and administer oxygen without considering the cardiac implications of the bradycardia. While oxygenation is important, if the primary problem is inadequate cardiac output due to a slow heart rate, oxygen alone will not resolve the issue of poor perfusion. This demonstrates a failure to prioritize the most life-threatening problem and a lack of understanding of the interconnectedness of cardiac output and systemic oxygen delivery. Professional reasoning. When faced with a patient exhibiting a slow heart rate and signs of poor perfusion, the advanced EMT must employ a systematic approach. This begins with a rapid primary assessment, including airway, breathing, and circulation. In the context of a slow heart rate, the circulation assessment must include a detailed evaluation of the cardiac rhythm via ECG. The NREMT curriculum stresses the importance of rhythm interpretation and the management of common arrhythmias. The professional decision-making process should involve 1. Assessing the patient's overall condition and vital signs. 2. Obtaining a 12-lead ECG to identify the specific cardiac rhythm. 3. Considering potential reversible causes of the bradycardia. And 4. Initiating appropriate interventions based on the diagnosed rhythm and the patient's clinical presentation, always within the NREMT-defined scope of practice for advanced EMTs. Question 19. Market research demonstrates that emergency medical service providers frequently encounter scenarios involving airway compromise. An advanced EMT arrives on scene to find a conscious adult patient who is clutching their throat, unable to speak, cough forcefully, or breathe. The patient appears increasingly distressed. Option A. Attempt to visualize the obstruction with a laryngoscope and remove it. Option B. Perform back blows. Option C. Perform abdominal thrusts until the obstruction is cleared or the patient becomes unconscious. Option D. Immediately begin chest compressions. The correct answer is C. Perform abdominal thrusts until the obstruction is cleared or the patient becomes unconscious. Explanation. This scenario presents a professionally challenging situation due to the rapid deterioration of a patient's airway and the critical need for immediate, effective intervention. The challenge lies in accurately assessing the patient's level of consciousness and the nature of the obstruction to select the most appropriate and life-saving technique, all while adhering to NREMT guidelines which prioritize patient safety and evidence-based practice. The correct approach represents best professional practice because it aligns directly with NREMT protocols for managing a conscious adult with a severe foreign body airway obstruction. Abdominal thrusts, Heimlich maneuver, are the recommended first-line intervention for a conscious adult who cannot cough, speak, or breathe effectively. This technique is designed to generate sufficient intrathoracic pressure to dislodge the obstruction. Adherence to these established protocols ensures a standardized, effective, and safe response, minimizing the risk of further injury or delayed treatment. An incorrect approach, such as immediately initiating chest compressions on a conscious patient, represents a significant regulatory and ethical failure. Chest compressions are indicated for unconscious patients or those in cardiac arrest, not for a conscious individual with a treatable airway obstruction. Performing compressions on a conscious patient with a foreign body airway obstruction would be ineffective in dislodging the object and could potentially cause harm, such as internal injury, and delay the appropriate intervention. Another incorrect approach, such as performing back blows on a conscious adult, is not the primary recommended intervention according to NREMT guidelines for this specific patient presentation. While back blows are used for infants, their efficacy and primary recommendation for conscious adults with severe FBOW are not supported by current NREMT standards. Failing to follow these established protocols constitutes a deviation from accepted standards of care, potentially leading to patient harm and a breach of professional duty. Professional decision-making in similar situations requires a systematic approach. First, rapidly assess the patient's airway status and level of consciousness. If the patient is conscious and demonstrating signs of severe airway obstruction, inability to speak, cough, or breathe, immediately proceed with abdominal thrusts. If the patient becomes unconscious, the protocol shifts to opening the airway, attempting ventilation, and if unsuccessful, initiating chest compressions followed by a finger sweep if the object is visible. Continuous reassessment of the patient's condition is paramount throughout the management process. Question 20. To address the challenge of a patient with severe facial trauma and complete airway obstruction, where bag valve mask ventilation and oropharyngeal/nasopharyngeal airway insertion have proven ineffective, and the patient is showing signs of impending respiratory arrest, what is the most appropriate next step for an advanced EMT operating within the NREMT scope of practice? Option A. Attempt endotracheal intubation despite the facial trauma, as it is the preferred definitive airway. Option B. Immediately initiate chest compressions and prepare for transport, assuming the airway is unmanageable. Option C. Proceed with needle cricothyrotomy as per NREMT guidelines for definitive airway management in this critical scenario. Option D. Reassess the patient's vital signs and attempt to manually clear the airway with suction before considering any invasive airway. The correct answer is C. Proceed with needle cricothyrotomy as per NREMT guidelines for definitive airway management in this critical scenario. Explanation. This scenario presents a professionally challenging situation due to the critical nature of airway management and the potential for rapid patient deterioration. The advanced EMT must make a swift, accurate assessment of the need for definitive airway management in a patient with severe facial trauma and airway obstruction, where standard airway maneuvers have failed. The challenge lies in balancing the urgency of the situation with the need to adhere to established protocols and indications for invasive procedures like cricothyrotomy, while also considering potential contraindications. The correct approach represents best professional practice by prioritizing patient safety and adhering strictly to the NREMT scope of practice and established clinical guidelines for cricothyrotomy. This involves a thorough assessment to confirm the indications for the procedure, such as inability to ventilate or intubate, and the absence of contraindications. The NREMT curriculum emphasizes a structured approach to airway management, moving from less invasive to more invasive techniques when necessary, performing a cricothyrotomy only when indicated, and when less invasive methods have failed aligns with the principle of do no harm, and ensures that the procedure is performed in a life-saving context, not as a first-line intervention. This aligns with the NREMT focus on evidence-based practice and patient outcomes. An incorrect approach would involve performing a cricothyrotomy without a clear indication, such as when adequate ventilation can still be achieved with less invasive means. This violates the principle of judicious use of invasive procedures and could lead to unnecessary patient harm, including bleeding, infection, or damage to surrounding structures. Another incorrect approach would be to delay the procedure when clearly indicated, and when less invasive methods have failed, leading to prolonged hypoxia and potential irreversible organ damage. This failure to act decisively when required constitutes a breach of the duty of care. Performing the procedure without proper training or in a manner inconsistent with established protocols, as outlined by the NREMT, would also be a significant regulatory and ethical failure, potentially leading to adverse patient outcomes and legal repercussions. Professional decision-making in such situations requires a systematic approach. First, assess the airway and breathing status thoroughly. Second, attempt all appropriate, less invasive airway management techniques. Third, if these attempts fail and the patient remains unable to be ventilated or intubated and exhibits signs of impending respiratory arrest, then consider the indications for cricothyrotomy. Fourth, confirm the absence of contraindications. Finally, if all criteria are met, proceed with the procedure according to established protocols and NREMT guidelines, ensuring proper technique and post-procedure care. This structured decision-making process minimizes the risk of error and maximizes the likelihood of a positive patient outcome.